We're going to talk about CKD, MBD. My disclosures. Let's start out with the case. 66-year-old, obese, male, black male, diabetes, hypertension. His BMI is 31. He's had diabetes for 20 years. His blood pressure, used to think this was reasonably well controlled. We recognize now that, is there some way to point? It's not. He's on an ARB, loop diuretic, insulin, multiple vitamin. He's on some vitamin D3. His GFR is 9. Potassium's 4.8, calcium's okay, phosphorus is elevated. 25D is fine. His PTH, you see, is quite high. Over the next 6 months, his GFR falls to 4. K is creeping up. Phosphorus is creeping up. 25D is still adequate. PTH is going up. Nausea, lethargy, weight loss. We start him on dialysis. What we're going to address over the next 2 lectures is what do we do with respect to his phosphate binders? What do we do with respect to dietary vitamin D, which is 25D3 levels or D2 levels that you measure, and this is replacement with D3 or D2, or activated vitamin D, 125D or the analogs. What do we do with this? Do we give him cinacalcet, calcium emetic? Is he at risk for vascular calcification, and can you prevent the calcification? We will address these issues over the next 2 lectures. Go taught us in the New England Journal of Medicine a number of years ago that as GFR falls, the rate of death from any cause goes up dramatically. And many of these deaths are due to cardiovascular events, 2 per 100 patient years to 36 per 100 patient years in patients that have a decline in GFR but are not yet on dialysis. We also know from Foley's data that dialysis patients, whether male, female, black, or white, have an incredibly high rate of death compared to the controls, normal people. A 30-year-old dialysis patient has almost 100 or 100-fold increase in cardiovascular death compared to the general population. This line is relatively flat. A 30-year-old dialysis patient doesn't do much better than an 80-year-old dialysis patient. And really, what's striking is a 30-year-old dialysis patient has about the same cardiovascular mortality as an 80-year-old non-dialysis patient. So our patients with CKD and those on dialysis are dying. They're dying at a prodigious rate. Much of this death is due to cardiovascular mortality. As you can see here, about 50% of those deaths are due to cardiovascular mortality. And our patients have traditional risk factors. They have diabetes, they have hypertension, they have lipid abnormalities. Our patients also have novel risk factors, inflammations, oxidative stress, etc. What we're going to talk about today are uremia-specific risk factors of phosphate retention, high PTH, vascular calcification that are killing our patients, and we have increasing data that we can do something about it to help prolong meaningful survival in our patients. CKD, MBD, as you know, is a constellation of laboratory abnormalities with vascular calcification and with bone disease. We know we have an elevated FGF23, PTH and phosphorus, declines in activated vitamin D or 125D3 and calcium. The overwhelming hypothesis, the hypothesis of CKD-MBD, is that if we have a positive effect on these laboratory abnormalities, we can decrease calcification and improve bone disease. And we're going to address that over the next 2 lectures. So what's the pathophysiology? It all seems to come down to phosphorus. Most of us eat about 1.2 grams of phosphorus a day. We absorb much of it. We secrete some back into the intestine, and the net absorption is about 800 milligrams of phosphorus a day. Goes into a small pool. On a daily basis, we are all making bone, we're all resorbing bone, but this is pretty much balanced in most of us, and we excrete exactly as much phosphorus as we absorbed, if your GFR is fine. However, we know that with CKD, as the GFR falls, phosphorus tends to go up, and you see calcium tends to go down. This is shown better in Kestenbaum's data. These are individual patients. You can see that at a GFR of about 30, the mean phosphorus really rises. It's still in a reasonable range, but it begins to rise. And we also know that this is accompanied by hormonal changes. From Adira Levin's data, we see that PTH goes up, as you all know. We also know that 25D goes down and 125D goes down. All of these hormonal changes can be thought to protect against an increase in phosphorus. An increase in phosphorus. PTH is phosphaturic, aids the kidney in excreting phosphorus. 125D causes intestinal phosphorus absorption. A lower 125D will decrease phosphorus absorption. We also know that FGF23, fibroblast growth factor 23, goes up dramatically. Look at these levels in end-stage renal disease and in patients on dialysis compared to a baseline. Between CKD1 and CKD2, there's a significant increase in fibroblast growth factor 23, which is not only phosphaturic, but decreases production of 125D. So what's the difference between FGF23, which I know commercially you can't measure today, but very soon you'll be able to order an FGF23 level in PTH. FGF is made in bone cells. PTH is obviously made in the parathyroid cells. Principal stimulus for PTH is hypocalcemia. Yes, 125D has an effect. Yes, phosphorus has an effect. But the principal stimulus is hypocalcemia. Phosphorus load, one of the many stimuli for FGF23. FGF23 is a phosphaturic hormone. It's incredible the amount of phosphorus a small infusion of FGF can result in the excretion of. PTH increases calcium and is also phosphaturic. Both are phosphaturic, as I've now said 5 times. FGF23 decreases 125D, PTH increases. You have to know this difference. In this cartoon by Miles Wolff, you see the sequence of events. The first thing that happens is FGF23 starts to go up at a relatively high GFR. Then 125D begins to fall, PTH begins to rise. All of these hormones are regulating phosphorus. FGF23 is phosphaturic, 125D increases intestinal phosphorus absorption, and PTH is also phosphaturic. Only when these 3 hormones fail to regulate phosphorus does phosphorus level begin to rise. Let's draw a cartoon of exactly what I said. High phosphorus, because the kidney simply can't excrete phosphorus as well with CKD, and I'll show you that data in a minute, leads to a high FGF23, which lowers 125D3. A high phosphorus itself also lowers 125D, and since 125D is made in the kidney, as you lose renal mass, you can't make as much 125D. Of the 3 regulators, FGF23 is probably the strongest. Low 125D3 decreases calcium, a high phosphorus absorption. High phosphorus complexes calcium and decreases arterial blood ionized calcium, and that leads to a marked increase in PTH. Also, high phosphorus stimulates PTH, and low 125D stimulates PTH, but on a scale of 1 to 10, calcium is at 10, 125D and phosphorus are 3s and 4s. This is the regulator. Both PTH and FGF23 feed back and cause this poor kidney that's failing to increase phosphorus excretion. However, these hormonal abnormalities and ionic abnormalities lead to bone disease and systemic toxicity, mostly vascular calcification. Now, I present that cartoon in a simplified manner. This is really what's going on. Every one of these ions interacts with every one of these hormones, principally through PTH. You can go through this. We don't have time today, but a high calcitriol inhibits PTH. PTH stimulates calcitriol. Go through these. If you understand this cartoon, you're in great shape. On a daily basis, on an hourly basis, on a minute basis, your and my PTH fluctuates down here. If I didn't have yogurt this morning, my calcium would be a little lower, my PTH would be a little higher. I had some yogurt, my calcium's a little higher, I suppress PTH. Minute by minute, second by second actually, we operate in this range. However, our patients begin to have this adaptive response stimulating PTH such that the glands get bigger, much like muscles get bigger if you use them. The problem is, as they get bigger, they have decreased receptors for vitamin D and calcium, so they're not so responsive, and they also become monoclonal, so they're even less responsive. These are simply ultrasounds of this cartoon showing that this is reality. These are the patients you see with a PTH of 2,000 who don't respond to anything except a surgeon's knife. As GFR falls, we see more FGF23 excess, more secondary hyperparathyroidism, and more hyperphosphatemia. It's simply a graded response of what I've told you. Why is this a problem? So Craver has a great study. He took patients Craver took patients CKD1 to CKD5 and showed, as everyone else did, that serum phosphorus increases. He showed PTH goes up. No news here. He didn't measure FGF23, but we all know that goes up. And what high PTH and high FGF23 do is increase the fractional excretion of phosphate. The amount of phosphorus presented to the proximal tubule, which is ultimately excreted, goes up due to the high PTH and high FGF23. However, 24-hour urine phosphorus falls. So in spite of the kidney trying to excrete massive amounts of phosphorus, 24-hour urine phosphorus falls because the fall in GFR is greater than the increase in the fractional excretion of phosphorus. So here's our problem. We're still taking in 1.2 grams of phosphorus. We're still absorbing a lot of that phosphorus, but because we're not excreting it, our patients are retaining phosphorus. So they're still absorbing, I lost my pointer, they're still absorbing 800 milligrams of phosphorus a day. Due to the high PTH, can I have my pointer back, please? Thank you. Due to the high pH, you can see bone resorption is greater than bone formation. And since you have as much phosphorus coming in from the intestine and more phosphorus coming in from bone, urinary excretion of phosphorus is less because Craver showed us the kidney's failing. So what happens? You begin to retain phosphorus in the cardiovascular system. You have more phosphorus going into the soft tissue, including the vessels, than is coming out, as you can see by the 200. I have no pointer. Thank you. More phosphorus going into the cardiovascular system than coming out, you begin to retain phosphorus. So what are the deleterious effects here? Vermeulen showed us that as plasma phosphate concentration increases, you can see on the right the decline in renal function falls. We also know from Kestenbaum's data that if you look at the lowest quintile of phosphorus compared to in the solid line, compared to the highest quintile in the yellow dotted line, you see that patients survive better, simply survive better. with a lower phosphorus than a higher phosphorus. This data on FGF23 is also quite telling. Kendrick, on the left, took pre-dialysis population, divided them into quartiles, right, groups of 4, and you can see that the highest quartile had about a 2-fold increase in death compared to the lowest quartile. On the right, Gutierrez did the same study in dialysis patients. And as you can see, in the 4th quartile, the highest quartile for FGF23, the odds ratio for death was about 5.5-fold compared to the lowest quartile. So FGF23 is associated, we don't know if it's causal, associated with increased mortality. And in this study, which is going to be hard to show without the pointer, which still doesn't work, we see that, in the look at the middle, the heart in sagittal section. We see that if you inject vehicle, the heart stays the same size. If you inject FGF23, there's a marked increase in cardiac hypertrophy. Heart weight goes up on the top. LV wall thickness goes up. Myocyte cross-section goes up. So there's biologic plausibility that the higher FGF23 is causing a problem. But we know something more now, and this clearly won't be on the boards this year, but maybe when you renew it will be. With progressive CKD, clotho levels fall. The clotho fall occurs before the increase in FGF23, and clotho also is a phosphaturic hormone. Clotho protects against fibrosis. Clotho inhibits vascular calcification. As your clotho falls, you can have more vascular calcification. So let's go back to calcium, phosphorus, and PTH. Phosphorus. Relative risk of death goes up when phosphorus is low or high. A low calcium is not a problem, except if the patient's symptomatic, and PTH appears to be far less of a problem than a high phosphorus or a very low phosphorus. But what's important to recognize is that at any level of phosphorus, if calcium increases, you have a marked increased risk of death. So the real killer is a high phosphorus and a high calcium. Interestingly, humans have about the lowest circulating phosphorus of anyone, any animal on this list, and live the longest. If you knock out clotho, the animals, don't live long at all, and other animals have far less life survival, again, correlation with phosphorus. But this is fascinating. Framingham data shows that in a patient without CKD, without cardiovascular disease, compared to the reference range of a pretty low phosphorus, if you increase your phosphorus, mortality goes up. Is phosphorus like blood pressure? The lower the phosphorus to a certain range, the better? Don't know. Let's think about calcification. Leslie Stevens did a beautiful study in dialysis patients. She took dialysis patients with a normal phosphorus, or less than 5.5, a low calcium, and a sort of high PTH, compared them to a higher calcium. Look what happened. Mortality went up. Then took in the same cohort of patients, those with a high phosphorus and a low calcium, again high PTHs, the same high mortality. So phosphorus or calcium matters. PTH, not so much. Whether the PTH was low or high didn't really affect mortality. But as you can imagine, a high phosphorus, a high calcium, regardless of the PTH, was the worst for a patient. 2 basic science slides, and then we'll get back to patients. Yang took vascular smooth muscle cells, put them in culture with a normal calcium, and increase the phosphorus, more calcium in the cell. Took a normal phosphorus, increased the calcium, more calcium in the vascular smooth muscle cell. And finally, he took a high phosphorus of 6.19, not so high in our dialysis patients, and increased the calcium. And look at the vascular calcification. It went up prodigiously. Last basic science slide, this cartoon by Giacelli. She took vascular smooth muscle cells, increased the phosphate, got increased sodium phosphate transport into the cell, increased intracellular phosphorus, upregulation of CBFA1, which is a transcription factor, also called RUNX2, which changes this aortic cell into a bone cell, which makes alkaline phosphatase, which makes calcium binding proteins, starts laying down collagen and calcium phosphate loaded matrix vesicles, which start mineralizing the collagen. And in the presence of a high phosphorus and a high calcium, you get this mineralized matrix. So the vessel, which used to expand in systole and contract in diastole, becomes a rigid pipe. That rigid pipe transmits the pulse pressure to the end organ, and in our case of our patients, kills our patients. So what are the consequences of all this? This is a great little study in kids, children. Normals don't have a lot of calcium in the vessel. Pre-dialysis, it goes up by a factor of about 2. Dialysis patients go up by a factor of about 4 compared to normal. These are adults, coronary artery disease in green. They have coronary calcium. Look at our dialysis patients. It's incredible how much calcium they have in the coronary arteries. If you do a bone scan of your dialysis patients, you see systemic calcification in kidneys. There's more calcium in the kidneys and the heart than in some of the bones. We know our non-diabetics and diabetics with CKD calcify. We know, this is again from Russo's paper, about half of our CKD patients have vascular calcification. Dave Spiegel showed about 2/3 of our incident dialysis patients have calcification, and Glenn Chertow, about 83% of our prevalent dialysis patients have calcification. What's important to recognize, and this is always on the boards, serum calcium does not predict calcification. Look at the serum calcium in these same 3 groups that I just told you about, and in Bill Goodman's teenagers with CKD, have the same serum calcium, all within the normal range, but they're calcified. Serum calcium does not predict calcification. Phosphorus, however, does. Coronary artery calcification is associated with increased mortality. This is from Jeff Block's study. As months go on, those with the highest initial coronary artery calcification score don't survive very well compared to those with the lowest score. In this study by Blatcher, he simply looked at the 4 major arteries at time 0 to determine if they were calcified. If 0 out of 4 were calcified, the patients did well. 1, not so well. 2 out of 4, not so well. 3, even worse. If 4 out of 4 arteries were calcified at time 0, the patient's survival was worse than most malignancies, short of perhaps pancreatic cancer. But calcification is killing our patients. Now you say, well, our patients don't have the intimal calcification that people with atherosclerotic cardiovascular disease do. They have the medial calcification that I just explained to you, that artery is still quite patent, but as I've said, it's rigid. It's a lead pipe. It doesn't allow for dissipation of the left ventricular force. It causes promotion of that pulse pressure to the arteries, and it kills the patients. Medial calcification is worse than no calcification on all-cause survival. Intimal calcification is even worse, but this is what our patients have. The lumen is patent, but they still have decreased survival and decreased cardiovascular survival. If they calcify their valves, they also have decreased survival. Let's think about bone disease, and then I want to kind of wrap a lot of things together. Renal osteodystrophy is alteration of bone morphology in patients. It's characterized by abnormalities in turnover, mineralization, volume, growth, or strength. It's a measure of the skeletal component of CKD and MBD. We know that as GFR falls, the odds ratio for a hip fracture goes up. We also know that trabecular density doesn't identify these patients very well. This curve, if it was quite sensitive and quite specific, should look like this. Well, it kind of doesn't. It's not very good at predicting fractures. But we know that as PTH goes up from low to normal to high, you move from adynamic osteomalacia to normal bone formation to osteitis fibrosa. In adynamic bone disease, you see there's not much cellular activity. The bone is adynamic, it's stagnant. With osteitis fibrosa, there's lots of osteoclastic activity, lots of osteoblastic activity. Our patients don't do well. KDIGO put together TMV, which is turnover, mineralization, and volume. Adynamic bone disease has low turnover, abnormal mineralization, and low volume. Osteitis fibrosa cystica, which is high turnover bone disease, has high turnover, abnormal mineralization, as does everything else, but increased volume. But even though the volume is increased, this isn't very good bone. It's not very strong. It's woven bone. It's like the bone that sort of infants have. It doesn't have the structural strength. See the nice long structural lines. This is much more random. So even though the volume might be increased, its strength is markedly decreased. So in both adynamic bone disease and osteitis fibrosa cystica, the bone isn't very strong for different reasons. Here you have less bone, here you might have more bone, but it's not of bone quality. And short of a bone biopsy, which virtually no one is doing anymore except in research studies, you can't tell the difference. PTH is about the best marker we have. It's a bit better than alkaline phosphatase. I show you this big table for one reason only, to show you that most of our patients have abnormal mineralization and have low turnover. Most of our patients have low turnover. You can see 24.9 on the top with low turnover and low volume. This is the most recent study by Hartman-Baruch. We lost the reference on here. Far more than high turnover. Why is this? Probably because we're using calcium-based binders and 125D, which is flooding the body with calcium and causing the low turnover bone disease. Now, why is this a problem? I told you that hip fracture goes up according to CKD. It also goes up according to dialysis vintage. Men on dialysis for more than 4 years have almost a 10-fold increase in hip fracture compared to normals, and much higher than men who have been on dialysis a far shorter period of time. The same with women. Women on dialysis for more than 4 years have a greater increase in hip fracture than women on dialysis for only 3 months. Why does this matter? Well, it matters because if a dialysis patient fractures their hip, their survival is essentially 0 at 5 years. Mind you, not so great if they don't fracture, but horrendous if they do. So we have to prevent this bone disease. So let me come back to this CKD MBD and talk a little bit about what we can do for some of this, and then we'll continue that in the next round. Calcification. We spent a lot of time talking about how calcification and how this kills the patients. It's association, it's also causal. We talked some about bone disease, about the abnormalities in turnover, mineralization, volume, and growth. We spent a lot of time talking about how FGF23 goes up, PTH goes up, and phosphorus goes up, and how 125D goes down and calcium goes down. Let me tell you a little bit about each of these. FGF23 caused cardiac hypertrophy in a mouse model, has the strongest association with cardiovascular death, both in the pre-dialysis patients and in the dialysis patients. If I give my patients 125D, FGF23 goes up. If I give my patients a calcium mimetic, FGF23 goes down. You can reduce FGF23 to 10% of its level by giving a calcium mimetic, cinacalcet. You can raise it by giving 125D. So if we don't know if that's going to make a difference, we have not done the study to show what happens with a patient who has a high FGF23 level and I lower it or raise it, will that affect mortality? PTH. If you lower PTH with 125D, you're going to get an increase in calcium and phosphorus absorption. Do you really want that? From all that I've shown you about the retention of phosphorus and how that induces vascular calcification, do you really want to use large amounts of 125D to lower PTH when you can use a calcium mimetic to lower PTH? Phosphorus. Is it like blood pressure? A high phosphorus associated with increased mortality, a high phosphorus driving the vascular smooth muscle cells to become osteoblasts, to become proper bone-forming cells, which cause medial calcification. If you can do one thing for your patient, it's lowering the phosphorus. 125D is low in our dialysis patients. It's low, as I showed you, because of the high FGF23 and low renal mass and high phosphorus. But if we give our patients additional activated vitamin D, it will cause calcium and phosphorus absorption. Do we really want to do that? There is some anecdotal data and some associative data that 125D saves lives. It might. We don't have a placebo-controlled, study to show that, but a little 125D, a mic or two, probably won't hurt. But many people are on prodigious amounts of 125D. I showed you that a high calcium is not good for the patient, is associated with increased mortality, but a low calcium, not a problem if the patient's asymptomatic. So we're starting to talk about the changes that we can make in each of these hormones and ions, and the way to do that, and on the next lecture, we're going to continue that theme. We have time for a couple of questions. With respect to phosphorus, an infusion of FGF23 will? Well, it's going to decrease the filtered load. That's the first part. Will it increase tubular resorption of phosphorus? Or will it decrease tubular resorption of phosphorus? Well, since it's a phosphaturic hormone, it's going to decrease tubular reabsorption of phosphorus. If you decrease tubular reabsorption of phosphorus, will it increase phosphorus excretion, not change it, or decrease it? And obviously, if you understand what tubular reabsorption is, and you decrease tubular reabsorption, you increase urine excretion. We're okay. And D is correct. One more question, and then we'll have time, a few minutes for questions from the audience. I give someone 500 international units of oral vitamin D3 per day. Let me just comment that some of you probably use D2, 50,000 units of D2 once a month or every couple of weeks in dialysis patients. Others of you use D3, oral D3, 1 or 2,000 units a day. Which is better? D3 has longer half-life than D2. So if you have a choice, and if your patient is adherent, it's probably better to use D3, which not only has longer half-life, but is more active than D2. D2 is, of course, a plant a sterol. So D3, over-the-counter, 500 units. What will it do? Well, will it change intestinal calcium absorption? Who wants to shout out the answer? So somebody said no change, not alter. Someone said increase. Vitamin D3 or D2 in its inactivated form. So we give vitamin D2 or D3. It's hydroxylated by the liver to form 25-hydroxy-D, which is the level that you measure and which the Institute of Medicine now says a level of 20 is sufficient, even though your lab reports probably say you need 30. But suffice it to say that a level of 20 is sufficient, is further hydroxylated by the kidney to increase intestinal calcium absorption. D3 on its own will not change intestinal calcium absorption. Won't change it at all. If you're D deficient and it's hydroxylated to 25 and then to 125, it will increase intestinal calcium absorption, and that's why I use the word directly. So it will not alter intestinal calcium absorption, so we're up to C and D. Well, if it doesn't change calcium absorption, which is the primary purpose of activated vitamin D, will it alter intestinal phosphorus absorption? Nope, pretty well linked. What will it do to bone mineralization? Will it, well, that's not an option. So the question is, alter intestinal phosphorus absorption or increase it. 500 units, a small dose of D3 isn't going to do anything to calcium, phosphorus, or bone. It'll make the patient, if they're vitamin D deficient, and if you walk down the streets of Boston, New York, San Francisco, or Calcutta, or any place, you will see people who have had rickets because of inadequate vitamin D. You'll see the splaying of their bones, but in fact, 500 units of D3 in URI isn't going to do anything to calcium or phosphorus absorption. So with that, we have exactly 2 minutes for questions. Who has the first question? Who has the second question? Yes, thank you.
Nowadays, vitamin D level is set by all internists, and everybody gets mega dose of vitamin D. Almost everyone whom we get referred to.
Right.
Even before coming to us,
yes.
My CKD.
So here's the data. In November of 2011, maybe later, the Institute of Medicine and National Academy of Sciences came out with a report, and I testified in front of that panel, on what the proper vitamin D level should be. They came up with a level of 20. Most of us, eating a reasonable diet and getting a little bit of sunlight, have a level of 20. It's sufficient. The problem with higher levels, according to the IOM report, is that in certain men there was an increased risk of prostate cancer. We don't know what megadoses of D3 will do, and there's absolutely no data that it's helpful. In the Institute, big report, 1,000 pages, 1,100 pages. You read the summary. There is no need for all that vitamin D. Years ago, it was a craze. Mike Hollick at BU, dear friend, and I love him, said people should have levels of 60, 70, wrote a New England Journal review on that. There's no data. And as I'll show you in the next slide, osteoporotic women, not next talk, osteoporotic women taking vitamin D and calcium have an increased risk of cardiovascular mortality of about 25% and an increased risk of stroke. My wife's a pharmacologist. When she read Boland's report, she threw away her bottle of calcium and vitamin D. I suggest that most of your patients do the same. If they need calcium, diet is much better than tablets, because the tablets are absorbed rapidly and it causes calcification. One more question quickly. Yes, sir.
So why are we giving the CKD patients D2 and D3?
So why are we doing it? That's what I'm here for, so we don't do it. Okay? In the past, we as a country were spending $1 billion on activated vitamin D. There was a competition amongst the companies to say it saves lives, it does more. Everyone was making a lot of, I hate to be cynical, making a lot of money on vitamin D. With the bundle, that's decreased. You don't see the advertising anymore. Giving your patients prodigious amounts of vitamin D to lower PTH is a fool's errand. And that's just not me saying it. It's all of my colleagues say the same thing. We just had a conference call last week. It's blinking at me. If I go over, the hook comes out and I get pulled off. We'll have more time later. Thank you.